Hi there, good evening everyone. I can see our numbers going up nicely. There must have been lots of you waiting in the waiting room, so thank you for that. Good evening if you're just joining. Welcome to this evening's session. We're just going to hold on just for a minute or two because I can still see lots of people joining, so we will just wait until those numbers start slowing down. Good evening to everyone who's just joined. I can see that numbers are still going up, so we'll make a start very shortly. Thank you very much to everyone for being here this evening. Okay, I think we're good to make a start. So good evening once again, everyone, and thank you for joining this evening's webinar from VI. We've got really good numbers as always. I had a little look at the registration list earlier on, and as always, it's a really good mix of newcomers and regulars. These webinars are always really popular, so thank you to all of you for being here this evening. If you haven't been to a VI webinar before, my name's Rachel Beecham. I'm the training manager for veterinary instrumentation. Before we start this evening's presentation, I'll just highlight a couple of bits around how this session is going to work. There are going to be some interactive questions during this evening's webinar, and that's to encourage a bit of interaction from our audience and to help us understand our audience better. To make the most of those interactive questions, it's better if you're viewing via a desktop rather than a mobile, because full functionality might not be available on a mobile phone. And when the interactive question box pops up on your screen, you should be able to move it around and expand it if you need to. Questions from our audience are very welcome. We definitely encourage you to pose questions as we go along. The Q&A function is open, so pop your questions in there and I'll put your questions to Colin at the end of the delivery. This webinar is being recorded. The recording link will be sent out via email within the next couple of days. And for everyone who's attending live this evening, I will provide an attendance certificate for you as well. So tonight's topic, as we know, is managing the challenge of anaesthetic hypothermia in our veterinary patients. Peri-anaesthetic hypothermia can be challenging to deal with, and this evening's session is aiming to give a really thorough overview of the topic, why our patients get cold, the implications of that, and what we can do about it. So it gives me great pleasure to introduce our speaker for this evening. First of all, I'd like to say a big thank you to Colin for getting up early to be with us this evening, because he's all the way over the other side of the world from me in Sydney, and it's 7 o'clock in the morning over there. I think I know Colin's an early riser as a rule anyway, but a very big thank you, Colin, for giving up the first part of your morning to be with us today. So Colin Dunlop is a graduate of the University of Sydney and a specialist in veterinary anaesthesia. His career path includes house surgeon at the University of Glasgow, resident in anaesthesia and critical patient care at the University of California, Davis, assistant professor of clinical sciences, associate professor, and chief of the anaesthesia section at Colorado State University. Colin's a diplomat of the American College of Veterinary Anaesthesiologists, and his research interests include prevention of anaesthesia, morbidity, and mortality. He consults in anaesthesia and critical care for both small and large animal practice, biomedical research, and he provides continuing education programs for vets and vet nurses worldwide. Colin is CEO of Darvall Vet and Advanced Anaesthesia Specialists, whose products are distributed by Veterinary Instrumentation, and which you'll see something of during tonight's webinar. So without any further ado, I'll hand over to Colin. All yours.
Thank you, Rachel, and it's a pleasure to be here this morning with you all. It is the morning in Sydney, so if you see me squinting a little bit, it's because the sun is coming up, and we're going to have a scorcher here today, I think. So it was pretty warm yesterday, so I don't know what the weather's been like in the UK, but it'll be fairly warm. And normally at this time of day, I'd be in a swimming pool swimming, and instead of that, I've decided that it'd be better to come and talk to you guys. All right. topic for today is managing the challenges of hypothermia in anaesthesia. And one of the things I would say is that I've spent a career in veterinary anaesthesia, and when I started as a student, you know, we knew patients got cold in anaesthesia. We didn't think much about why that happened. We just thought, well, they get cold in anaesthesia, and at the end of anaesthesia, you put them in a cage, chuck some blankets over them, maybe throw a hot water bottle in there, and that was pretty much it. And we didn't really spend a lot of time thinking about how important is this for our patients, and is this really the best care we could give them? So today I'm going to try to give you a little bit of information about particularly what I've learned over the last 20 or 30 years, both in clinical veterinary anaesthesia and also as a result of the work that we've done as a company that has tried to address this problem and understand what the problem is so that we can do a better job clinically. So our goal is, firstly, to improve patient safety. Secondly, to do the best job we can within the limitations of trying to do it efficiently so that the environmental cost benefit is reasonable. Secondly, or thirdly, to do it in a way that's economically efficient, and also to make it easy for us to do it in clinical practice. If something's easy to do, we'll do it. If it's difficult to do, we'll say we're going to do it, but we really won't do it. So the first thing I'd like to do is learn a little bit about what you guys do. And Rachel, I think you've got a question to put up for us. Is that right? So the question is, what systems of warming do you currently use in your practice today? And we'd just like to have a bit of a guide to see what people are really doing. And some of you may do more than one thing, but and I'm sure you do, but you know, give us an idea of what you're really doing. This is to educate us as much as it is to educate you.
I can see lots of answers coming in there, Colin. That's 40% of our audience who've answered. So we'll just leave that up there.
That's great. So I can see that we use, what's interesting is we're not using a lot of circulating warm water pads. They were very common when I started in anaesthesia 30 odd years ago. That was that and electric heating pads and insulation and things. We also used heating lamps. So we've moved away from those kind of things, and we're using heating pads and insulation. And I thought I had maybe there was another answer on the bottom I can't see, which is
you should be able to scroll up and down, Colin, on that.
Oh, I see. Right. Let me just have a look there. Okay.
So I've just shared those audience answers so we can see the spread of answers there.
Right. So it looks like the main things people are using, if I started at the bottom, a reasonable number of people use IV fluid line warmers, warm air blankets, electric heating pads in some form appear to be the majority. And of course, everybody's putting insulation on tables. We're still using things like water-filled containers. All right. So we'll just move on. Right. Do I need to shut this, Rach?
Just move on to your next slide, Colin.
Okay. Righto. It seems to be shut here. There we go. Maybe that's... There we go. Right. So the first question I want to ask you guys is an animal with a temperature of 33 degrees that bad? And why did I pick 33 degrees? Because that used to be, and I think still we see animals finish surgery at 33 degrees. but that used to be a pretty common thing. And we'd put an animal in a cage, make sure it had some kind of warming, probably sit with it or have someone observe it till it's extubated, extubate the animal, and generally might be in a room where people are observing, but walk away from it. I'm an ocean swimmer. It isn't that cold in Australia compared to the UK, but I can tell you that when the water gets down to 16 degrees centigrade, to compete in ocean swimming in Australia, you can't wear a wetsuit. So you basically got to swim in your budgie smugglers. I did a 5K swim last Sunday at Manly, the Cold Classic, and you're in the water for about an hour and 15 minutes or so. And at last weekend, it was about 21 degrees, something like that, very comfortable. But at 16 degrees, it gets cold. And at the end of 2 kilometres, you think, I just want to get out of here. A human with a temperature below 35 degrees centigrade has mild hypothermia. They have uncontrollable shivering and perhaps don't make great decisions. At 33 degrees centigrade, you have moderate hypothermia. People have increased confusion. And at about that temperature, they stop shivering. And that's a sign that people are actually getting really cold. And then those people, if they presented to an emergency room, would probably spend some time in ICU being warmed up. Humans below 32 degrees centigrade have severe hypothermia. They do stupid things like take off their warm clothes and walk away from them while still being out in a cold environment. Their muscles become rigid, and the treatment for people once they get down below that sort of a temperature includes extracorporeal warming. And they take that very seriously. We walk away from animals in cages at temperatures down at 32 degrees centigrade. And what we do know is that at 32 degrees centigrade, those animals can be sitting there looking at us. But the reality is that animal is probably not really capable of looking after itself and can easily become unconscious and not really be aware that its behavior has changed. If we look at morbidity mortality in anaesthesia, 50% of anaesthesia mortality occurs in recovery. The mortality rate of small animals is probably around 1 in 1,000. It might be a little bit higher than that, might be 1 in 2,000, but it's certainly not any better than that compared to human anaesthesia, where the mortality rate is 1 in 300,000, 250,000. So we have a substantially higher mortality rate in veterinary medicine, and about 50% of it occurs in recovery. And maybe putting these animals in a cage at 32 degrees centigrade and walking away from them, or 33 degrees centigrade, is part of that problem, because those animals end up in a corner, their head gets kinked, their airway becomes obstructed, their nose falls into the warming blankets or whatever, they don't breathe, and basically die. We certainly walk past a cage, see a conscious animal, think it's okay, walk past that cage 15 minutes later and the animal's dead in the cage, and we don't really know why. What we do know is that the temperature of animals is dependent, is really the temperature that we are looking to measure is really the core temperature of an animal. When we look at animals, we have the temperature of the core, which is the central organs in our body, which we're trying to maintain at a fairly narrow range, typically between 35.7 and 30, under 38 degrees centigrade. The peripheral tissue, the skin, the subcutaneous tissue, the fat, the muscles, they're the insulators that are trying to keep that core temperature constant. And they have a far greater capability of varying their temperature by up to 4 degrees centigrade. We maintain our core temperature by vasoconstriction and vasodilation. So when it's hot, we vasodilate. When it's cold, we vasoconstrict. And the thing that you must appreciate is that for an animal to lose 1 or 2 degrees centigrade, for the temperature to drop, that is a tremendous amount of heat shift. The heat shift, the heat capacity of a body is defined as, or the heat capacity of substances is defined in joules or calories. I can explain calories in my mind easier than joules, because a calorie is the amount of heat it takes to warm 1 ml of water 1 degree centigrade. If you have a 10 kilogram animal, that is a 10,000 ml animal. A kilogram is a litre. It takes 10,000 calories to raise that animal's temperature 1 degree centigrade. It's a very important thing to understand. So when we induce anesthesia and an animal loses 2 or 3 degrees centigrade in a matter of minutes, that's a tremendous amount of heat to lose. And you can't lose that heat through the skin simply by radiation. And the way you lose that heat is you transfer blood from the core to the periphery. You have a temperature difference between the core and the periphery of 2 or 3 degrees centigrade, and suddenly you've put the blood in a fridge. And that's how animals lose heat. So, Rach, would you like to share the second question? So the second question is, how do we measure core body temperature? And I've given you some answers there to think about.
That's just over half of the audience who've submitted
Right.
an answer.
And I'm going to give you an answer now because I can see what you're all doing. It's really interesting. Your answers, there's nobody should feel bad, but most of you don't have this right. The people who answered the temperature of the urine in the bladder are right, and all the other answers are wrong. The measurement of core temperature is something that, Rach, I just want to move to the next screen. How do I do that?
Yeah, just click onto your next slide, Colin.
Yeah, it does. It locks up when I'm. Let me just see what happens here. Did this before.
There you go. You're there.
Okay. Right. Right. The answer is that the esophageal temperature with the sensor located between the heart and the diaphragm would give an estimate of core temperature. Okay. But the esophageal temperature in at the thoracic inlet is not the core temperature. It's the temperature reflected by the heat transfer between the air and the skin and the thoracic and that area of the thoracic inlet. To measure core temperature, you either need to measure the temperature of the blood. You can do that with a Swan-Ganz catheter. You can, and usually in a central location near the heart. You can measure the temperature of the esophagus between the heart and the diaphragm, not with the temperature probe in the stomach. And the other way you can reasonably easily get core temperature is from measuring the temperature of urine in the bladder. And all those other measurements, including rectal temperature, are measuring temperature, but they're measuring the temperature of things like the feces. And here's, I'll go over this data again in a minute, but here is some data from a research project, a very good research project done in macaques looking at hypothermia. And what you can see here is these are the same animals, the same time points, and on the left is rectal temperature, and on the right is esophageal temperature with the probe between the heart and the stomach. And you can see they're different. And the difference is that the rectal temperature is close to the surface of the body. You've got the effect of the feces themselves, which may hold some heat, but they dampen the temperature. And the temperature on the right is the temperature that is most reflective of the temperature of the blood. So when we measure temperature of animals, what we're most interested in is the core temperature. And in clinical vet medicine, most of the time what we're measuring is something between that temperature and the peripheral temperature, such as shown on this graph on the left. Right. So another question I would ask you to think about, looking at these couple of, this is some examples of how we did anaesthesia in the about 1960. On the left, pentobarbital, a dog on a stainless steel table, tied down, probably because it had no analgesia, and relying on anaesthesia to prevent patient movement. And on the right, we see a later period of time with, this is at Colorado State in the 1980s, late 80s, and we can see a cat on a hot water blanket using a heater lamp and things like that to try to stop this animal getting cold. What we're looking at here is surface heat loss. Heat loss on the left from the animal to the table, and heat gain on the right of the cat through the surface of the skin. We did a lot of research in cats in the 1980s. To keep a cat warm in our research lab at 37 degrees for about 4 hours, we had to have the cats on a warm water blanket in a room heated to about 24 degrees, cover the cat with a plastic, like a Glad wrap or a plastic bag, and then put insulation on the top of that, so towels and things like that. And then we had a heater lamp on the front of the cat. And then we could keep the cats at about 37 degrees. So my question for you is, how many of you have measured the temperature of a dead animal? And I bet very few. You need to do that. It is a very illuminating experience. And you think, this guy is nuts. Next time you euthanize a dog in the practice, and it's not perhaps, maybe it's a stray animal, or the owners are going to come, the owners aren't wanting to see the body immediately, leave that animal on a table in the treatment room, and you take its temperature every 20 minutes, half an hour, and you'll find that that animal's temperature does not change very much for several hours. That animal is losing heat through its skin to the room. And if the room's at, say, 24 degrees centigrade, then the net heat loss is from the body to the room through the skin. That is surface heat transfer. That animal's temperature remains incredibly stable for several hours. I've had residents pull an animal out of a fridge or freezer that was euthanized 20 minutes before to make them take its temperature, to see that the animal's temperature is still almost its body temperature. So animals do lose heat through their skin. They do gain heat through their skin, but it is incredibly slow and inefficient. So the question is, how do animals get cold very quickly? Well, here's a couple of thermal images of cats. The cat on the top is a cat in a cage, a conscious cat curled up. The cat on the bottom is a cat that has been just anaesthetised, intubated, on a radiology table, about to have some radiographs taken. So the cat on the bottom's been anaesthetised for maybe 5 minutes. Look at the cat on the top and you see it's curled up, its hair's standing up. The only real heat loss in that cat is coming from its ears and its nose, maybe the very front of the the stifle area and tibia area of the leg. You look at the cat at the bottom who's been anaesthetised, and the greatest heat loss in that cat is coming from the distal limbs and the head. And why is that? Because the cat has vasodilated. It has shifted blood from the core of the cat to the periphery. And that is how animals lose heat rapidly from the time of induction to the time you get them into surgery and draped up. Heat loss is not a linear function. It is a linear function in the dead dog on the table, but it is not a linear function in a live animal. In a live animal where there's blood flow, what happens? We can look at this idealized graph, and this graph's been made from many studies of heat loss or hypothermia and its management. And what you see along the bottom, you can see the first section is from the time we pre-med the animal to the time of induction, the time of induction to when we start the surgery, and the time of surgery. So that period from induction to the start of the surgery is where we prep the animal, roll it around on the table, getting it ready. And then once it's in surgery, it's positioned, draped up, and pretty much lying in one position. And what you see is that animals lose up to about 1 to 2 degrees centigrade from the time of premedication up to the time of induction. They lose that heat and they're still sitting in a cage. So they're vasoconstricting their periphery and trying to conserve their heat in their core. You induce anesthesia. Most of the anesthetic drugs we use today, parenteral and injectable and inhalation, cause vasodilation. So the animal shifts blood out to its periphery, just like that thermal image. Once the animal's in surgery, its temperatures drop probably between 2 and 4 degrees centigrade. So its temperature's closer to the room temperature, but also it's draped up and probably has some insulation or under table heating. And the heat loss stabilizes, and their heat loss in surgery becomes similar to the heat loss of a dead animal. And you can see that. Warming animals up is the exact opposite of this. So if you want to warm an animal up from the skin, you start on the right side of this graph on the blue line, and you start pouring the heat into the skin. And slowly you heat the subcutaneous tissue, the blood, and then the temperature rises. And everybody listening to this webinar who has ever warmed up a cold animal in recovery knows this. When you put animals in recovery, even with efficient heating systems, you take that animal, it monitors its temperature, and nothing happens for maybe an hour and a half. And then suddenly its temperature starts to rise, and then it rises quickly. And that exponential heat gain is the exact opposite of the way the animal lost its heat. So heat moving in and out of an animal is very much a function of shifting blood and shifting the heat via the blood. And the skin itself, well, it's designed to be an insulator. So the skin is not efficient at transferring heat into the blood rapidly. It takes time, and it typically takes 40 minutes to an hour to really be able to transfer heat through the skin with constant contact. So if you're in the prep room and you're rolling that animal around, you don't have constant contact with the heating device, so the transfer of heat is going to be very inefficient. Heat loss comes from many things. It comes from the relationship between the body mass and the skin surface area. Smaller animals get cold generally faster, and but they're faster to warm up. If you get a Labrador cold, it might take hours to warm that dog because it's got tremendous insulation from its skin and subcutaneous fat. The origin of heat loss begins with premedication. At the time of premedication, we change the vasomotor tone, we change shivering, and animals start losing heat from their periphery, particularly their distal limbs, and they manage that by vasoconstriction. And they pool the blood into the central vascular pool or the core area of the animal. Heat loss from airways with intubation and breathing cold, dry gas, clipping, exposing skin. I've got various thermal images of animals that have had degloving injuries. So a cat that's had basically all the skin peeled off its back legs. Those animals lose an enormous amount of heat quickly. They're almost impossible to keep normothermic under anaesthesia. We reduce heat loss by draping animals, covering animals, but we don't stop it. And the heat loss is exacerbated by exposing the internal organs, the core part of the animal. And the other thing during anaesthesia is the animals stop shivering. In recovery, you can put a cold animal in a recovery cage, and as long as it starts to wake up from anaesthesia, it will start to shiver. And when it shivers, it will warm up. So assessing the efficacy of warming devices in recovery and say, look, I've got this device, I've put it on the animal and it's warming it up, and suggesting that that device is warming the animal is probably misleading, because the animal's going to get warm itself by shivering. I think the real test of efficacy of warming devices is, can you warm a cold animal up in surgery? Because that takes a lot of heat to achieve. There are many things that we've used historically to warm animals, everything from warm water bottles, all those things that were in the question and answer I asked you. And one of the things that we need to ask ourselves is, are these things effective? The question I just asked, can these devices warm a cold animal in surgery? Because if the only thing you can say is that I can warm these animals up in recovery, you have to ask yourself the question, is the animal warming itself by shivering, or is your device actually making a difference? And that question I'm going to ask again later, but we're all becoming more aware of the environmental impact of what we do. The most expensive environmental impact is heating animals and people, heating water, warming us, generating heat. Using energy to generate heat is the most expensive cost of what we do environmentally, generates the most CO2. So if you use a warming device that is not effective, it is generating a huge amount of impact, and it's having no positive outcome. So I think the onus is on us today to be more aware of what we're doing, to be more critical of how the devices are that we're using. And then the other aspect of this is the device itself of potential risk to the patient? And the risk of patient warming is to burn patients. I will talk more about heating in recovery in a little while. Okay, Rach, could we have the next question, please? So my question now is, which devices are least likely to cause a burn? Are you there, Rach?
Yeah, I'm here. Have you launched one of the polls, Colin? Because this is telling me that question's unavailable.
No, I haven't done anything.
Bear with me.
I don't think I've done anything.
This has never happened before. My launch button is grayed out.
One of the things, Rach, when I was trying to move from the question to the next question, is it wouldn't let me do that. Let me ask you guys this question. You may not be able to answer this online.
I've done it.
There we go. Okay. So the question is, which of these warming systems on that list is least likely to cause a skin burn? And the bottom that everybody's answering, that's where you basically coil up the IV line and stick it under the animal, right? And why do I put that in there? We make heated breathing circuits, and about 8 years ago, 6 years ago, someone rang me up and said, I burned an animal with your circuits. And I thought, oh my Lord, they've burned the airway of an animal. And in fact, they'd coiled the hose up and laid an animal, a cat having a dental. And then they, just to make sure, turned the cat over and burnt the other side. And the cat laid on the hose for about an hour and a half on each side. And there were all these little lines on the cat lining up with the corrugations of the hose. So it looks to me like the majority of people have picked the IV fluid line warmer. And I can't ask you this question out and get an answer back from you, but my question to you is, why did you pick that? Now, I'll tell you, everything else on that list has burned animals. The microwave bags filled with grain, the problem with them is that the center of the bag is much hotter than the periphery. So when you heat that bag up, if you're overachieved, the center of the grain bag or the handful of grain is much hotter than the periphery. You put that next to an animal because it feels okay, but then the heat transfers out to the peripheral grain, and now it's hot enough to burn the animal. Electric heating pads, there are two ways they burn animals. The thermostatic control fails, but more interestingly, there's a phenomenon where if you lay an animal on any heating device, an electric heating pad's the classic. Let's say it's a bigger dog, it's been clipped, and the dog's skin gets maybe wet, so in the prep and the clip, so now you've got a point of contact like the point of the hip. And where that maximum contact and pressure is, the heat transfer from the pad to the animal increases. And the electrons are going to travel down that heating pad to that point of heat transfer, and the temperature of the surface of the pad at that point will be significantly higher, up to 20 degrees centigrade, than the rest of the pad. And that's how you can, we know this from work we've done with heated breathing hoses. Containers of warm water, very high risk of burning if the temperature of the water is high enough. And circulating warm water pads, generally a failure of a thermostat. Heater lights, depends on how close you get the heater lamp. I was at Colorado State many years ago, and we'd have 6 or 8 animals in surgery at the time, so the techs and the anaesthetists would be walking around from room to room. I walk past this room and I see the ventilator going on and off, and under the drapes are rising and falling with the ventilator, and I'm thinking, what's going on here? So I walk in the room, lift the drapes. They've got the heater lamp under the drapes right up next to the corrugated tubing. It's almost melted. So every time the ventilator cycled, they blew up like a balloon, and then the ventilator would cycle off and they'd go back down. And it was just, I would say, minutes away from a bad outcome. So what about the IV line fluid warmers? Let me see now. So let me try this, Rach. It doesn't like me, this thing. See, I've just clicked next. So how do I get rid of this poll without upsetting you? Will I click the little X on the top corner of it?
Just minimize it off your screen. I've made it go away for the audience.
Okay, let me just try and move it. There we go, I'll do that. There we go. So the answer, the IV fluid line warmer. The IV fluid line warmer, and I'll talk a little bit more about them, but the temperature of the fluid in an IV fluid line, 200 millimeters, 20 centimeters from the fluid warmer will be the room temperature. So if you laid an animal on the IV fluid line of the fluid warmer, it would actually be transferring heat into the IV fluid. There'll be no heat in the IV fluid going back to the animal. I'll show you why in a second. Right. Oh, here we go. Right. There we go. So IV fluid line warmers, I would put them in the category of Are they pointless? Depends on how you use them. They're designed to heat fluid. The test that they are required to complete to get an IV fluid line registered by the US FDA for human use is that they heat the fluid at a flow of 200 mils a minute to a maximum of 43 degrees, 1 to 20 centimeters from the warming device. So right where it comes out to 20 centimeters away, it can heat the fluid to 43 degrees. The fluid temperature drops very quickly in the line, and by 20 centimeters from the IV fluid line, the temperature will be the room temperature. And the other problem is that they may prevent heat loss to some extent, but they are almost ineffective to raise the temperature of an animal. It's back to the 10-kilogram dog. The 10-kilogram dog, if you look down there just above the red line, is a 10,000 gram or a 10,000 mil dog. It takes 1 calorie or 0.83 calories to raise a mil 1 degree centigrade. So if the dog's temperature is 33 and I've got to raise it 4 degrees centigrade, if you do that math, I need 33,000 calories. And my IV fluid line warmer is going to deliver less than 300 calories an hour if the animal's close enough to the fluid warmer that the fluid's actually warm. So I'm not going to tell you that these things will do nothing. It is better to heat the fluid than not heat the fluid. The distance of the fluid warmer from the patient is very important. And you can see that once the fluid flow gets up above 200 mils a minute, they become less and less effective. So for small animals under 20 kilos, there's possibly some benefit in terms of preventing heat loss. There's not much efficacy in terms of heat gain. What about burning animals? There is an exponential relationship between the temperature at which we apply heat to the skin and how fast we burn the animal. This was work done in pigs. And you can see that at a temperature of 60 degrees centigrade on the left there, we will have a full thickness skin burn, a 3rd degree burn in 5 seconds. At 50 degrees, you can see that it's going to be around about 2 minutes. Oh, sorry. And at 45 degrees, you can see that it's suddenly you're getting up beyond an hour. For most human medical devices, they set a high temperature limit of around 43 degrees. And if I come out here at about 43 degrees, you can see that the contact time is now 5 hours. And so this is, if you come back here to 60 degrees centigrade, that's how we burn animals with hot water devices. And you see the picture of the dog on the right. That's a little poodle type dog. Honey's that dog's name. We burned that dog in 1998 and I still remember it. And that dog was burned. It was not burned by us by a referring practice, but by placing that dog on a hot water bottle. And there you can see it. And the dog on below it was burned by a hot water circulating blanket where the thermostat failed. These burns are incredibly difficult to treat, very time consuming. You have to resect all that skin. You have to basically, if you can, move enough skin to pull it together. The dog above there had the top of its pelvis exposed for about 2 months. Right. So hypothermia does cause problems. It is probably a part of the reason why we see a mortality rate in recovery that is at least the same as the mortality rate during anesthesia. It's associated with slower heart rates, respiratory depression, slower metabolism of drugs, less efficient distribution of drugs. If you're treating pain in a hypothermic animal, the drugs are probably not as well distributed. Pain at surgical sites due to shivering, vasoconstriction, reducing the distribution or the delivery of analgesic drugs, and then things like airway obstructions in recovery, and always the risk of burns. In this day and age, we really probably should be using thermostatically controlled devices to warm patients. Certainly in human medicine, there would be no heating device used that has not got some thermostatic control. Hypothermia slows recovery times, maybe up to twice what they'd normally be. The slower the recovery time, the more time spent looking after that patient. The patient becomes semi-conscious, and the first thing it does is pee and poo. So then you've got to change the bedding in the cage. You've got to change the dressings if they get soiled and things like that. So there are many reasons why we ought to get animals into recovery that are normothermic, and we should use heating devices that are effective. The question that I would ask, and I've already asked this question, is, are all these devices the same? Do they all deliver heat? We put a heating device on an animal, it makes some noise, blinking lights come on, it looks good. Is it actually working? Right, what's the fourth question there, Rach? Could we have that, please? So I'm going to ask you a question that I've actually just talked about, and that is, how long does it take to cause a full thickness burn of an animal? At what temperature? And it looks like you've listened, and I like that. So the answer is the answer that right now about 65% of people are giving, okay? So it takes about 5 seconds, 3 to 5 seconds to burn an animal at 60 degrees centigrade. I'll just pull that down here. And you can see the right answer is the second one. So I asked how long it takes to burn an animal at 55 degrees, and the choice I gave you was 30 seconds. It takes 15 seconds. At 45 degrees, it takes about 5 minutes. And at 42 degrees, it takes maybe 5 hours. So 42, 43 degrees. So it's high temperature for a really short period of time, particularly if the animal's clipped, if the skin surface is wet, so you improve the contact between the heating device and the animal. That is where animals are at most risk. If you're going to use surface warming from things like hot water bottles, and you know, there are always times where we think, yeah, we should do that, and it's okay. I would say 2 things. Always wrap those devices in some kind of insulation, a towel. Never put those devices against clipped or bare skin. Put them against skin that's covered with hair. And those 2 things will actually provide some insulation that will reduce the risk of burning. When it comes to active warming devices, things like, I'll talk a little bit about forced warm air heating. We've spent a lot of time looking at forced warm air heating, blankets, heaters, all these kind of things, looking at thermal images and various methods of measuring heat delivery. What I will say is that most of the devices that are used to blow heat into forced warm air blankets, the big hair dryer, they all have the capability of delivering warm air. So you can see here, they're all delivering about the same amount of flow at around the same amount of pressure, and the temperature that they achieve is similar. So they're all trying to achieve a temperature, if their devices developed for human medicine, at around, the cutout is going to be at around 43 degrees centigrade. So they're aiming for a temperature delivery of between 39 and 43. What I can say is that from the actual hairdryer itself to the animal, the actual tube, you can see here, the thermal images showing you the tubes of heaters where there's no insulation. and the tube of a heater on the lower right where there is insulation. If you cover the tube, you reduce the heat loss from the tube, so then you actually deliver heat to the blanket that's at 42 or 43 degrees. Otherwise, you're going to lose 2 or 3 degrees centigrade before you even get the heat into the blanket. So the other thing about these heating devices, they should have thermostatic control. They all will have a temperature sensor inside the box. Ideally, they should have a temperature sensor down near the hose inlet. And if they get to over 43 degrees, most of them will cut out. An insulated cover will improve the performance, and you don't want leaks. You want the system to join to the blanket without having holes in the hose. So dragging a hose on the concrete floor will put all little micro holes in it. The same from your waste gas tubing. So the more you drag it around on the floor, the more little micro holes will be in it, and the more air that will leak out. We want the heater ideally to be off the floor, and we want to have some kind of a HEPA filter in that heater, ideally that the end user can change. So you can see down the bottom there's the HEPA filter that fits in underneath this heater. The heater's off the floor, so it's not going to pick up air, and we can easily change that heater filter typically once about every 500 hours, which is about 6 months of use in a typical practice situation. Another thing about blankets is, are they all the same? You can see on the right, the top right of this, the picture of an actual blanket with a long inlet between the blanket and the heater hose connection. And if you look to the next picture, the middle picture of the thermal image, you can see that a tremendous amount of heat is being lost at that point. So that long lead into that blanket is actually an inefficient design, because the heat is permeating out of the system before it actually gets into the blanket. The blanket in the center has too much resistance in the blanket and too much permeability of the surface, so the heat is coming out of that blanket right after the hose inlet, and it's not dissipating down to the sides and the end of the blanket. So blanket design matters. We know this. This data was presented in 1999, and I don't know why it's a very good study, and why we kind of see something like this and then we just keep on going. So 1999 is 20 years ago and 24 years ago. And what this is, it's a bear hugger blanket used with cats. 4 groups of cats, one with no heating, one with the blanket on all the time, one with the blanket off for half the surgery and turned on for half the surgery, and the blanket turned on for half the surgery and turned off for half the surgery. And what you see there is no difference. So however they set that up with that blanket and that heater, it didn't do anything. What we've known, and these are blankets we manufacture, and we test equipment, we look at equipment, we try to understand how to make it better. In the center are the blankets that we made in 2000 till about 2017. And you can see that blanket has a little elbow inlet. The heat comes in on the left-hand side, does a little jog around, goes up the blanket becomes narrow at the bend and it's got a little kink in it, and then it comes down the other side. What we've learned is that if you want heat to flow around the blanket, it's just like gas flowing in an anesthetic machine. What you want is a low resistance, low turbulent gas path, what we might think about as laminar flow. And the blanket on the right, you can see, has no kinks. The bend at the top of the blanket is bigger, and you can see that the gas is making it, the heated air is making it all the way down the other side of the blanket. And the other thing that's different about that blanket compared to the center blanket is that the pillows of the blanket are much closer together. And what we also know, historically, we used to think, well, we put the animal in the center of this thing, and the heat is going to transfer from the air across to the skin of the blanket into the animal. And I've just spent half this talk telling you that transferring heat through the skin is inefficient. The way to make it more efficient is to get the blanket to contact the skin of the animal. So the animal lies in here and the blanket pillows are tight enough that they actually touch the side of the animal. So here's a model of a blanket on the left where you've got a lot of pillows and the animal's just lying amongst them. And you can see that the heat is the maximum at the point of contact. And if that was a live animal, at that point, we'd be measuring about 37 to 38 degrees centigrade in that point of contact, whereas out here would be 30, say 36, 35 degrees by the time you get to the periphery of the blanket. So having the blanket tighter against the animal matters. And then on the left, we can see an older blanket where the heat's coming in. This is a recovery cage blanket. The heat's coming in at the side. And this blanket has, up the length of the blanket, has little joins between, little gaps between the air pillow, so that theoretically the air is going to go across those gaps and get across to the pillows on the other side. And what those gaps cause is turbulence. And what turbulence does is cause heat loss. So you can see that down near the inlet, the blanket's working very efficiently, but at the other end of the blanket, it's less efficient. So if we go to a blanket design where we have long pillows that are tapered and that there's no cross flow in that blanket, the heat dissipation across the surface of the blanket is actually better. So we've spent a lot of time looking at how to get better heating from blankets. The other thing I would say is that we've already talked before about how long does it take to put heat into an animal. And even with efficient systems, 35 to 45 minutes is fairly good. So for a long procedure like a dental, you really should be putting the animals on a blanket. That's efficient because these animals are often old. They're often small body mass. Their older animals have less body fat. And the procedures often cause the animal to get wet, and the animal is there for a reasonable amount of time. So I would suggest that apart from surgery, the one group of animals that really ought to be getting the benefit of effective heating systems are our older patients having dentals. And these are the patients we used to put in cages at 33, 34 degrees centigrade and walk away, like that cat on the lower right. I took that picture probably in 1987 or 88, and we'd walk away from that animal quite happily. And these are probably the animals that are at risk because they're really not what I would describe as compos mentis. And they're the animals that could curl up, get a clot in its nose, get its head in a corner, get an airway obstruction, and then they quietly die and nobody realizes. There's lots of different blankets. Some blankets patients lie on top of, some patients lie underneath the blankets, some blankets are designed for cages, some blankets are designed for surgery. And depending on how you, what your application is, there are different blankets that are going to suit that purpose. One thing I'd point out on that blanket on the lower right, you can see that all those blanket pillows are tapered. So the blanket's more like the shape of a kite, and that's the sort of shape you need to get the most efficient heat transfer. Right. What about infection? And I think that there's a lot of how would I describe it? Myths and legends. You know, this device is going to cause infection. This device is not going to cause infection. To answer the risk of infection from forced warm air heating, you really have to go to multi-center studies done in thousands of people. And there's some references there at the bottom of studies that have been attempting to answer the question, do these devices increase the risk of surgical site infections? And what we know is that there is no evidence in laminar flow surgeries that the use of a warm air heating device in the surgery alters the laminar flow characteristics of that surgery or increases the bacterial contamination of wound sites from the air. What we do know is that hypothermic patients have an increased risk of wound infections. We also know that a normothermic patient appears to have a lower infection rate compared to a patient that is hypothermic. That's what we can learn from multi-center studies of humans. What I would say is that in veterinary medicine, where people tend to reuse things, I think the first thing is you really should be concerned about the maintenance of heaters. If I put the hat on of somebody who runs a business that services equipment, the heaters that come into our service facility to have filters changed are filthy. And I think if you're using heaters in surgery, you really should be changing the filters in those heaters on a regular basis. And the other thing is that these studies are all done in human surgeries where the blankets are a loose weave polypropylene new blanket. They're not washed, they're not reused, they don't have lint in them. And it's the lint that's in the blanket that probably is getting blown around a room. You know, when you put clothes in a hairdryer, you've got to clean the filter. That's the lint. We should have another question there, Rach.
Does that come up for you, Colin?
I can't see it, but oh, hang on. No, yeah, I can. I've got it down the bottom. Right. So the question is, which statement's true with the use of forced warm air blankets? And this is really probably reiterating what I've just talked about. And it looks like most of you can see that normothermia reduces the risk of wound infections. So whatever we do, having a normothermic patient is going to be better than having a hypothermic patient. Okay? So the evidence based on human research is that normothermia will reduce the risk of wound infections and that the risk of wound contamination from a heating device with clean, lint-free blankets and a maintained heater with an effective HEPA filter is very small. It's no greater risk than the risk of infection itself. Right. So we've answered that. Right. What about warming in recovery? We do a lot of things to warm patients in recovery, and everybody should be commended because that's obviously a concern for us. So we're trying to address that concern. But here are some examples of things that I see all the time that, particularly if you're using warm air heater to warm a patient in recovery, you should be wondering about. The top right, jamming a heater hose in a cage door and destroying the heater hose. Now, that heater hose is not going to transfer heat particularly well. I've already showed you thermal images of hoses without insulation. When you pinch that hose down like that, A, you damage the hose, B, you cause turbulence, so you're causing heat loss at that point. The hose below has multiple, looks like multiple lacerations and damage to the surface of the hose that's repaired with the faithful vet wrap, but I would suggest that that hose needs to be replaced. And if that hose had a cover on it, it would suffer a lot less, particularly from dragging it on things like concrete floors. connecting the heater hose in the case of the bear hugger picture below on the left, we've got a heater hose extension connected that's going to connect to a cage door adapter, but it's connected up to a hose that's full of holes. That heater is not going to put warm air into that blanket. And the picture above shows a cloth blanket joined to a heater hose with vet wrap, and the blanket's not inflated. Take the blanket away, put a towel over the animal, and it will heat up just as effectively. The research that we've conducted on warm air blankets, one of the things that we've learned is that the blankets need to inflate tight like a lilo, one of those air pillows you'd ride in the surf. And if the blanket inflates tight, it's much more likely that that blanket is going to have effective heat transfer when I put a thermal camera on it than if the blanket's limp like it is in this dog here. So none of these things are particularly effective, but turning that heater on is going to consume a huge amount of power, generate a huge amount of CO2, and achieve nothing. We obviously, years ago, started making kennel door adapters, and this is the third generation of adapter we make. And the point of this adapter is to enable you to quickly connect a heater to an animal in a cage, and then to have that joint where it goes through the cage not leak air, and have a relatively airtight system so you can inflate the blanket like it shows here, so the blanket's tight. Why do we want to heat animals in cages? Well, obviously we want to heat animals that are cold in critical care and post-anaesthesia. We know that if we do that, it's going to take an hour and a half, maybe longer. If I warm an animal up before anaesthesia, how long is it going to take? 30 to 45 minutes. I can cook the animal. If the animal's cooked, its feet are warm. So when I induce anaesthesia and the animal vasodilates, its blood goes out to its feet that are warm. There's no heat transfer. If I pre-warm animals, I can pre-warm 2 to 3 animals in the time I can warm 1 animal in recovery. That's 3 times as efficient. If I use the blanket over the top of the animal and it's not clipped and prepped, I can reuse the blanket. So I'm going to be able to reuse the blanket. That's an environmental efficiency. I'm going to heat the animal in 1/3 of the time than is if I tried to warm an animal in recovery. Pre-warming is the single best thing you can do to change how you manage heat loss in your practice. It needs to be efficient. The system needs to be airtight. It's got to be an effective heater delivering heat effectively to that animal. But if you pre-warm animals, small animals for 30 minutes, bigger animals like Labradors for 45 minutes, you're going to induce anaesthesia in an animal that's peripherally warm. If you cover it with a blanket and it's on an insulated surface in the prep room, maybe with some under table or electric heating, then get the animal into surgery efficiently and draped up, and its heat loss will be stable. If we can drape up animals in surgery that are 36.5, 37 degrees for an hour surgery, they should hold that temperature. We don't warm animals in recovery that are above 37 degrees centigrade. Here's a Jack Russell. This dog was hit by a car, had severe pelvic fractures. This dog came in the day before as a critical care patient and had a radiograph taken under sedation or anaesthesia the day before, and his temperature got down to 33 degrees centigrade. We pre-warmed this animal to 38.7 degrees centigrade before induction. We got this animal into surgery at 36.5, and this animal held 36.5, 35.5 throughout the surgery. So its temperature was stable during surgery, and it held the temperature at which we draped the patient. That's the benefit of pre-warming. Warming animals in recovery. Do cloth blankets work? New cloth blankets work if the material the blanket is made of is semi-permeable. So not like a pair of surgery pants with the two legs knotted and the air blowing up and the waist knotted, because that's a cotton type material and all the air is going to leach out at the start. If you look at the blanket at the bottom, which I'm holding up, you can see that the blanket is limp. It's folding in the middle. If that fold is where the animal is, such as in the picture at the top, that's causing obstruction to airflow and turbulence. It's causing heat loss. So the heat is coming out of that blanket at the inlet, this area here, but it's not getting transferred to the patient. We can see here two pictures. The one on the left is a limp blanket. The one on the right is a stiff blanket. The stiff blanket is ducting the air much more effectively around to the patient than the blanket that is limp, where the temperature around the patient is actually cooler than the temperature of where the air is flowing into the blanket. So the picture on the bottom right is what I mean by a blanket that inflates where the air pillows are stiff. So if you want to know, does your heater work, you should be able to pick that blanket up at the hose connection, and it should maintain that stiffness when you lift it up off the animal. And if it's hanging there like a limp noodle, I can tell you it's not transferring any heat. It is no more effective than a towel. And here you can see an example on the top left of a new cloth blanket, and on the bottom, a washed cloth blanket. And you can see that that washed blanket's become more permeable, just like any cloth does when you wash it a number of times. And the air is dissipating out of that blanket at the inlet. The blanket on the right is a fairly stiff blanket, and you can see I can pick it up and it holds its shape. Without putting a thermal image on it, the two blankets at the top are far more effective than the blanket at the bottom, and the blanket at the right is probably more effective than the blanket at the left because of the kinks in that blanket on the left. What are the alternatives to warm air blankets? Well, one of the areas that we've spent a lot of time looking at is heating the gas going to an animal. We know that animals lose a lot of temperature in the first 15 minutes of anaesthesia. In the anaesthetic prep room, it is really difficult to heat animals. Putting an animal on a surface, like a warm surface, like a warm air, like an electric blanket with a towel on it, whilst it is stopping the animal from losing heat to the surface of the table, is not going to be effective without contact time between the animal and that surface for about 30 minutes. So all the heating that you do in the prep room is really to stop heat loss into the surface of things like the table, rather than effectively delivering heat to the animal. The one thing that we can do that can effectively deliver heat in the prep room is to heat the inspired gas that the animal's breathing. Because as soon as the animal's intubated, we can warm that gas, and we can warm that gas at a temperature that is going to effectively deliver heat to the patient, and it's going to do it from the moment of intubation. I didn't include, I've got data, but I didn't include it, that we've done a lot of measurements of temperature transfer as gas moves down the airway. If you put a probe down the airway of an animal with 12 temperature sensors every centimetre down that airway, what we know is that the temperature loss in the trachea from the endotracheal tube connector to the end of the endotracheal tube is 10 degrees centigrade. So whatever heating we do, if we only heat the gas that the animal breathes to about 35 or 36 degrees, by the time it gets to the end of the endotrach tube, it's going to be about 25 degrees, which is the room temperature. If we don't heat the inspired gas, the inspired temperature will be the room temperature. The breathing tubing behaves just like the IV tubing for our IV fluid warmer. So if we heat the gas right back up here at the breathing system, by the time it flows down that tubing and gets to the patient, it's going to be the room temperature. So what we do is we heat this inspired limb, the limb with the orange cuffs on it, all the way down to the Y piece. And there's a temperature sensor right there at the Y piece. And we are trying to heat that gas to about 43, 44 degrees centigrade, because we know that between that point and the end of the endotracheal tube, the temperature is going to be dropping about 10 degrees centigrade. And what we're aiming for is an inspired temperature of about 35 degrees, 34 degrees centigrade, rather than the room temperature, which in most surgery rooms is going to be 22 or 24, in that sort of range, degrees centigrade. Can you effectively heat an animal with heated tubing? The answer to that question on its own is no. And why is that? Because the animal only is going to breathe maybe 12 times a minute, inspirations for a second. So 12 seconds a minute, it's taking in room air, taking in inspired gas that's warm. And for about 48 seconds a minute, it's losing heat. So these devices are going to deliver heat effectively. They're going to prevent heat loss from breathing cold, dry gas. But as a warming device on its own, it is probably not going to be effective. So we certainly, pardon me, we certainly use these devices to effectively deliver warm air to an animal in the prep room and also in surgery. But to actually warm the animal, you need more than just heated breathing systems. Can you effectively warm? So these pictures here show heated circuits on circle systems. One thing I'll say is that we need to have one breath sit in this hose for it to warm effectively. So what we need is when the animal breathes in, the next breath is sitting in that inspired limb and it gets warmed up while the animal breathes out and before the next breath goes into the patient. We can use standard circle systems on animals down to about 7 kilos. We certainly have circle systems that are designed to go down to animals as small as 2 kilos. And by using smaller tubing, smooth wall tubing that has laminar flow, we can effectively heat that gas. For animals where you have patients below 2 kilos on a low flow circle system or 7 or 8 kilos on a standard circle system, we'd normally use a non-rebreathing circuit. As I said before, one breath has to sit in that hose before the next breath goes into the patient. So if you're going to use non-rebreathing circuits, the non-rebreathing circuits we can effectively heat are the ones where we have inspiratory flow and expiratory flow in different tubes, and that's a LAC circuit. All the other non-rebreathing circuits we can't effectively heat because they have continuous gas flow. So we can use a LAC circuit, and if we use a small volume Y piece, this is a Y piece we developed that has a volume of about 1.3 mils, we can use that Y piece. We tell people down to 1 kilo. Lord Smith Animal Hospital in Melbourne is the largest humane society in Melbourne, and they use they actually use this circle system with that Y piece, and they put animals down to their early spay neuters, which are about 1 kilo, or maybe a little bit smaller. So by using a small volume Y-piece with very little dead space, about 1.3 mils, we can put animals down to about a kilo on a lax circuit or a circle system if it's a low flow circle system, and effectively warm the patient or warm the inspired air. The Y-piece has a little bit of a funny bend on it. And the reason for that is to avoid the need for an elbow connector. This is the study that's done in macaques. And what this data shows, both the rectal temperature and the esophageal temperature, is that animals heated with heated tubing, which is the two lines at the top of the graph, is more effective than animals heated with a standard warming system below it. So the animals on the lower line are the animals heated with forced warm air blankets, and the animals above are heated with forced warm air blankets and heated tubing. And what you see is the temperature that they achieve is higher, the response time to warming is faster, and what you also see, the graph on the right best shows this, is that heat loss is just as we've described. Rapid heat loss at the start of anaesthesia, a period of about 45 minutes with warm air, the animal on a warm air blanket, and then the temperature starts to rise. We can improve this performance and increase the speed of warming and the rate of warming by using heated circuits combined with warm air blankets. So that is the most efficient way to warm a cold animal in surgery. Question 6, if we can have it, please. Rach. So question 6 is based on the study of heating macaques, which statement is true? You can't see all of that, or can you? I'm not sure, maybe on your screens. Warm air blankets can increase body esophageal temperature in 10 minutes. That's the first one. Warm air blankets can increase body or esophageal temperature in 25 minutes. The second one. Most heat loss occurs in the first 15 minutes of anaesthesia. The fourth one is heated breathing circuits alone can effectively increase body temperature. And the last one is heated breathing circuits combined with warm air blankets makes no difference to warming. And I think everybody's got the message. And the message is really the correct answer is most heat loss occurs in the first 15 minutes of anaesthesia. And the bottom answer, heated breathing circuits combined with warm air blankets, makes a big difference to warming because it's probably the most effective way we can warm animals in surgery with the technology we have. So effective external warming combined with some internal warming. Okay? All right. Thank you. Right, we'll just go on to the next question. So that's what I've just said. We can heat devices with the same equipment for exotics, and that's just to show you that we make devices where the warm gas or the inflow gas flows through a heat exchanger here down into a system where there's unidirectional flow in the masks, and we can deliver warm air to the nose of something like a rodent, which has substantial blood flow to its nose, and then you can provide effective warming to those animals. So the same kind of idea. Right. The last thing I want to talk about is a little bit about the environmental cost of what we're doing. And I've talked about this as we've been going along, but let me just show you some hard numbers that might make you think a little bit. Heated circuits. It's a 36-watt device, runs at 24 volts DC. A forced warm air heater, most of them are 1500-watt heaters. They heat 300 litres of air a minute. That heater, if it's used 1,200 hours a year, so that's roughly using the heater in a practice, running the heater. If you used it an hour a day, it would be 5 hours a week, 20 hours a month, 240 hours a year. So that's saying we're going to use this heating device for 4 hours a day. The heated circuits use 156 megajoules. The warm air heater uses 6,400 megajoules. The heated circuits generate 0.035 tonnes of CO2 a year. If you burn coal bought from New South Wales coal mines that generate 0.8 tonnes of CO2 per 1,000 kilowatts of heat generation. And on the right, we generated 1.5 tonnes of CO2 running our warm air heater. If I can tell you one thing today that is of value from an environmental perspective, don't use heating devices that don't work, because that's what's costing us heating water and then not using it. Using a heating device that's not transferring the heat to the patient. Because we can sit here and argue about, what we can do that's going to make a difference. What we can do that's going to make a difference is not turn that device on the right if we don't have to. And when we do turn it on, to make it effective. Pre-warming is 3 times as effective as warming cold animals in recovery. Warming animals with a heating device that is not working is a waste of energy and is generating CO2 for nothing. That's the most important message I can give you from an environmental perspective. What about washing blankets? When we do things, we've got to you've got to look at the cost from the start to the end. The cost of washing a blanket, if you use your machine an hour a day for 200 days a year in the practice, that's 200 kilowatts of power. It's going to generate 0.16 tonnes of CO2 a year. That's okay. If we're going to dry the blankets, it's going to take 1.5 hours a day to dry this load of washing. We're going to generate 0.6 tonnes of CO2 a year. So now we're getting up to the level of CO2 production from running our warm air heater ineffectively. So that's generating 1.5 tonnes. Washing and drying is going to generate 0.7 tonnes of CO2 per year. What about making the blankets? Well, interestingly, the cost energy-wise of producing and weaving fibre to make fabric is about the same for all fibres. The best studies have been done in wool. Cotton, flax, polypropylene are reasonably similar. But what you can see there is if you compare that to washing and drying, we can generate 4 cloth blankets for the cost of washing and drying a blanket, or we can generate, let me back up. The total megajoules to produce a kilogram of fabric, which is that center column, will produce 4 cloth blankets and about between 8 and 11 polypropylene blankets, 1 kilogram. The 3,300 megajoules of washing blankets would generate nearly 200 polypropylene blankets, okay? So that gives you an idea of the proportional energy cost of what it is we're actually doing. Since COVID, a lot of work has been done on the cost benefit of things like polypropylene loose weave masks compared to cloth masks made of some kind of effective cotton material. And you can see there, if you look at the 2 lines, the line at the top below the pictures is the cost of manufacture in terms of the kilograms of CO2 produced, and the line below it is the cost of washing or disposal. And washing masks is an expensive energy proposition, just like washing blankets. So we've got to balance these things up. And there's no right or wrong answer, but you've got to understand that what you're doing, every aspect of that has an energy cost. And the best way to look at the environmental cost, particularly in terms of global warming, is to look at CO2 production. So the last question, I think we could have, please, Rach. So which of the following questions is true in regard to patient warming? A, heated circuits and warm air heaters use the same amount of energy, so produce the same CO2 emissions. B, there's no difference in the amount of energy to weave fibres into fabric based on fibre type. C, using warm air heaters with new or reused blankets both produce effective warming, so environmental cost benefit is the same. D, it's much more energy efficient, so the CO2 emissions are the same, to wash and dry cloth blankets than to manufacture loose weave polypropylene blankets. And it looks to me like, you know, people are obviously thinking about this, and I think that's commendable. And I think probably, you know, we've all got biases as to what we want to believe or not believe. But the one true statement of those four statements is that that there is no difference in the amount of energy to weave fibres into fabric based on fibre type. And the other three statements are actually incorrect. If I can just go to the answers there for you. And you can see there's a reference at the top, and you're welcome to take a screenshot or go and have a look at that. But that's a reference from the textile industry looking at the efficiency of manufacture, and they're also looking at the efficiency of disposal of textures and of textiles and the ability to recycle them. But you can see that a 1500 watt warm air heater generates 6,000 megajoules a year compared to 150 for a heated circuit. So substantially different. The cost of running a 1500 watt heater, if it's ineffective, has a high environmental cost for no benefit. Washing blankets generates around 3,000 megajoules a year, so half the cost of driving the warm air heater itself. And manufacturing one cloth blanket requires about 40 to 50 megajoules. One PPE blanket requires about 20 megajoules due to the weight of material. Okay? All right, so I would say, in summary, pre-warming is the most effective thing we can do from a cost-benefit analysis. We can use heated circuits to deliver warm air, particularly in the part of the procedure where heat loss is high and it's very difficult to deliver heat. For surgery times less than an hour, whatever heating device we apply to that animal in the surgery, draping the animal up is going to effectively reduce the heat loss to a more linear function. And for surgeries less than an hour, it's probably not long enough to have a lot of heat transfer into the patient. I didn't talk much about humidifiers, but the important thing about humidifiers is that you get rain out below 32 degrees centigrade. And if the heat loss down the trachea is 10 degrees centigrade, the rain out happens in the trachea. So they don't maintain humidification unless the temperature is above 32 degrees centigrade. And I'll show you an example of that in just a second. And if you need to use recovery warming, use effective devices, because otherwise what we're really looking at is the animal warming itself by shivering. to finish up, I'm going to show you a little bit of video of an animal on heated circuits on a circle system that weighs 2.5 kilograms, just to show you that this is an animal having intraocular surgery. And I should be able to make this run. Can you guys see that, Rach?
Yeah, all good, Colin.
So we're looking at the head of the animal, and he's intubated. He's actually on a standard white piece. We didn't have those little white pieces before that. Standard sort of monitoring, blood pressure, and we've got a small blood pressure cuff we make for these guys. Heated tubing, heating the gas going to the animal, from the animal, back up to the circle system. And what I want you to see on the circle system is how much moisture there is in the expired limb. That's because the inspired limb is heated, so the water vapor is maintained as vapor all the way to the animal, and the rain out is now happening in the expired limb. In your circuits, the inspired limb has the water vapor in it because it's raining out there, not getting to the patient. This animal's being maintained on about 1.5% with a fresh gas flow of, it looks like 300 mils a minute. You read to the top of the bobbin, the pressure in the breathing system 0, so that the animal's breathing quite well. Its temperature is 35.5, so it has lost some heat, and the monitoring is fairly straightforward with a normal end tidal CO2. So the point of that was really to how do I get out of that? Right.
Are you able just to click onto your next slide?
I think I've killed it.
Oh.
I think I've killed it. I'll get down to here. And that's the end of it. And so, did you guys see it? Can you see that? Or have I still got the screen showing my video?
You've gone back to your YouTube screen.
Okay.
Don't worry, Colin.
Right.
I think.
Well, that was my last slide, and really it just said I wanted to thank Rachel for all her work to put the webinar together, and thank you guys for giving us your attention. It's getting late there, and I do appreciate that. And I hope that we've asked some questions that have made you think a little bit, and maybe think a bit about what you do in your practice. Go back, take the temperature of a dead dog. It is a very educational experience. It will make you believe that what we're doing and what we're saying is real. And then we've been telling people, teaching people, and not just us, I think a lot of anaesthetists, a lot of people in critical care, the benefit of pre-warming. And I think you shouldn't underestimate that. And then be more critical of the devices you're using to warm animals, because I think we probably can do better. And some of it is that we're using devices that are probably not ineffective, but we want to believe that they're working. We all are trying. We're all trying to do the best job we think we can, but sometimes you need to step back a little bit and take a hard look and go, is this really working? And I hope I've given you enough information tonight that you can at least be a bit more informed about what it is you're doing and how it's actually doing the job that we want it to do. Be happy to answer any questions, Rach.
Yeah, we've had some questions come in on the Q&A. So when you were talking about measuring the temperature of the urine in the bladder, one of our audience members asked, can the bladder be voided to take the temperature of the urine?
You mean express the urine and take the temperature of it? Well, theoretically, you could do that. The heat loss is going to be really fast. Let me answer the question like this. I anaesthetize horses. We take a blood gas of every horse we anaesthetize. When we take the blood gas, we want the temperature of that blood syringe to be cold, so we don't metabolize the oxygen and affect the reading. So we put it into iced water. But if I take that blood gas and carry that syringe to the blood gas machine, put it in the blood gas machine, it's not 37 degrees, it's something less than 37 degrees. So then when I put in the temperature correction for my measurements that I've made in the animal, they may or may not be correct. So heat loss from fluid, it's just like the IV fluid line. The heat loss from the fluid, 20 centimeters from the device, it's going to be room temperature. So that's the problem with trying to measure voided urine. It's losing heat as you're standing looking at it. So you'd have to void it and measure it immediately with a thermistor that can respond almost immediately. I suppose you could collect it into a warm device or an insulated device.
That's helpful, thanks. Just to clarify, when we're talking about pre-warming animals, you start pre-warming them immediately following pre-med? So pre-med back in the kennel, warming
Yeah, for sure. I mean, that's probably the ideal way to do it. The reality is that you need to pre-warm small animals, and small, I'm talking animals under 10 and 5, certainly 5 kilos. You're going to need to warm those animals for about 30 minutes with an effective warming device. If the animals are bigger, it takes longer. So more like 30 to 45 minutes. So you don't have to pre-med them and sit them there for 45 minutes. If you put them in a cage with a warming device, look at your average dog. If you put the dog out on the, out in a yard where there's some sun, or in the UK, maybe in your sunroom, the dog's going to find the sun, curl up and go to sleep. So most animals are quite happy to lie on a warming device and let themselves get warmer.
Okay. And someone's asked, how warm do you have the animals with pre-warming? So what temperature are you aiming for, I guess, to work?
Well, what we're really aiming for is to warm their feet. How much do you need to warm them to warm their feet? Maybe half a degree. The animals are generally conscious. Most animals that are pre-medded are conscious enough that they can move away from the heat if they want to. That's why we use a warm air blanket over the top. It doesn't get soiled. They can crawl out from under it if they want. I would say my experience is very few animals do that in the time that we're warming. If you left them there for a long time and they didn't thermoregulate, they could get warmer. 38.5 is plenty.
This is a good one. I think you're going to like this one. What would you, first of all, a thank you for a great presentation. And then the question, what would you consider the most effective way to keep the temperature up in reptiles, snakes, to be specific?
Okay, well, reptiles are tricky because reptiles have a lower temperature. So if you're going to use a thermal device on a reptile, probably you're talking about warming them to about 37 degrees, 38 degrees. And they also, as a species, they're designed to absorb heat, both the light, so the color of the animal is designed to absorb light or the infrared heat radiation. And secondly, their bodies are designed to absorb heat through the surface more efficiently. That's why reptiles like to sit on a warm rock, something like that. So a reptile, I would say, surface warming is effective. You just need to use it at an appropriate temperature and probably to have some thermostatic control, because there's obviously no hair covering, so it's easy to burn.
Okay. Someone with a question about warming IV fluids. Should I not bother to heat up my IV fluids right before surgery?
Yes. Should you not bother? I think you've got to be realistic about what you're doing. Heating the fluid and getting the fluid into the animal at a temperature between the room temperature and 37 degrees is going to prevent heat loss from running cold fluids in. So running cold fluid in is going to cool the animal. Perhaps not as substantially as you think, but it's still going to do that. So heating the fluid bag itself and hanging a fluid bag up that's at, say, 37 degrees is certainly going to help. I think if you're going to heat the fluid, be realistic that if the animal is 20 centimeters, 200 millimeters down the IV line from the heating device, it is going to be at room temperature. So I've worked in anaesthesia practice for 30 years, and I've gone through cycles of curling IV fluids up into kidney dishes of water and all this sort of thing. And I would say most of the time I don't warm the fluid line, but we do try to hang up bags of fluid that are at least room temperature, not chilled, or that are warm. So most of our fluids are in a warm cabinet, come out at 37 degrees, and we hang them up.
Okay. There was another question about taking the temperature of the urine bladder. I'm not sure when that question came in, if you were answering the question as the question was being typed, but just for clarity on how you would take the temperature of urine.
Well, it's not something that's been commonly done. That's the first thing. It's not something that people have been doing regularly, although they do in human medicine, because bladder catheters can have temperature sensors implanted into the catheter itself. The alternative is to put a temperature sensor into the bladder. Our heated circuits, so the heat controller, we have an animal temperature sensor, and a standard temperature sensor is 3.4 millimeter diameter. We make a small diameter temperature sensor that's 2.4 millimeters. So it's about the thickness of the lead in a pencil. And that's a much smaller sensor that you could put in the bladder. Probably should be at least clean. So in other words, you would want to clean that sensor with something like HibiCleanse and sterile water, or use a sterile sensor, which you can buy in human medicine, catheters that have temperature sensors in them. It's not something that's been commonly done in vet medicine, but I think it's something we should think more about, because it is the one place we can truly measure core temperature of an animal. You can also measure core temperature in humans at the back of the pharynx, so in the nasopharyngeal recess. And that's another place you can put the temperature probe, but it's a harder place to locate in the mouth of an animal, and you've got to keep the probe in that spot. Okay?
Yeah. We've had just another couple of questions come in. I know we are running a bit over time. When do you stop actively warming? At what temperature would you stop introducing heat?
I wouldn't warm animals at the end of surgery that are over 37 degrees unless you felt there was a very good reason to. I'd let them warm up themselves by shivering a little bit. I would certainly not warm animals over 38 degrees, and I would caution anybody that if you have an animal that is septic, a fever, has a problem of auto-regulating its temperature, if you're going to use active warming devices, you must monitor them continuously. I've seen at least 2 animals killed where they were put on warming devices, electric blankets covered with towels, or maybe a warm air heater over the top, that were post peritonitis surgery. And I've come back and the animal's lying there panting, nobody's really paying attention, and its temperature's 43 degrees and it can't auto-regulate. And one of those animals died. We turned the heat off, we cooled it down immediately, got a fan on it. And I'd been out of the hospital, and I came back, and as soon as I walked in and saw this animal, I realised there was a problem. And that animal ended up dying a couple of hours later because it couldn't auto-regulate. So do not use active warming devices without continuously monitoring the temperature of any animal that has a fever or is septic.
And the last question we've had come in is along similar lines. Some pre-meds cause panting. If you're going to introduce heat after pre-med, would you cause dehydration, or should the patient be on pre-op fluids?
I don't, well, we all, dogs pant that are conscious and they don't dehydrate, or they do a little bit, but their nose recovers the moisture. That's what our nose is designed to do. It's designed to humidify the air going in and to recover the moisture going out. But as we all know, in the middle of winter, if you walk up to a mirror and blow out hard, you'll get moisture on the mirror. So it's effective, or our nose is efficient, but not 100%. I don't think for the short period that's necessarily a problem. I certainly haven't seen that. And most animals are going to get some IV fluid when we set them up in the prep room to induce them, or after they're induced. What that question does raise is a question that I do ask students and interns in anaesthesia. And that is, if you're monitoring a patient in surgery and it is breathing over a ventilator or tachypnic or panting in the middle of surgery, what are the reasons for that? And there are 4. The animal is responding to painful stimulation, the animal is hypoxic, the animal is hypercapnic, or the animal is hot. If you've got a pulse oximeter and the saturation's over 90%, it's not hypoxic. If it's even over 87%, because the pulse oximeters underread the saturation by 2 to 3% on the peripheral tissue bed, they're not hypoxic. An animal with the CO2 under, a small animal at a reasonable plane of anaesthesia with a CO2 under 50, 55 is probably not going to be tachypnic. If you've eliminated CO2, pain, and oxygenation, you need to be concerned that you've cooked the animal in surgery. It's possible to do it. It's not common, but if you use very efficient warming devices, particularly where the body cavity is not open, it is possible to overheat an animal. So tachypnic animals are a reason to monitor body temperature in surgery, obviously, but tachypnic animals, you need to eliminate those 4 causes of that clinical sign. Okay.
That's great. Yeah, that's really helpful. I'm going to draw a close because we have run over time. So massive thank you to Colin for a really great presentation. It's been a really informative session.
And thank you to everybody who has persisted and sat through it, because it's obviously the start of my day, but it's the end of your day. And I would say it's getting to that time of the evening where you should be relaxing.
I think we will relax very shortly, actually. Colin, what I forgot to tell you on our pre-call is that when I hit end on the webinar, it kicks us off as well. So I'll send you an email afterwards.
No
But
problem.
Huge
Thanks,
thank
Rach.
you, Colin. And a really big thank you to our audience for your participation and for all the great questions that we've had come in. For those of you who are still online, if I can just ask for a couple more minutes of your time, there will be a survey that pops up on your screen when I finish the webinar. If you could just leave some feedback, that feedback comes directly to me, and it's truly very, very valuable to me to help me improve these webinars. Colin, thank you again. Pleasure as always. And
thank you, Rach. You did a lot of the work.
You're welcome. Catch up
Righto.
soon. Thanks very much, everyone.
Right.
Bye.
Good night.
Bye-bye.